And in 2022, we launched a scaling up of mama. And when we look at the global building blocks for health, you will see that issues of referral system, it bites on service delivery, it bites on finance, it bites on issues related to infrastructure. So those are the areas whereby it bites. But when you come to the social description of delays, it bites on the first delay and the second delay as well. So taking this holistically, you will see how the political will comes into being. And for all of us, we know the 4R whereby our president is passing through. The first is reconciliation, the second is resilience, the third one is reform, the last one is rebuilding. And you can see mama, it fits very well with the issue of rebuilding. And it's not surprising that among the first things which were launched by President Samia includes the mama. And I would say this provides the biggest anchor because she was, from when she came in office, when she was addressing the parliament, she said, the project for maternal and newborn care is within my heart, and I'll make sure within my time we make a huge investment in this area. And this is one of the salient investments you can see through our presidency. And I can say we can build from there saying that political will has been a biggest driver towards the establishment of mama, and now which is covering the entire country. I submit.
Thank you very much, Dr. Makwani. Indeed, Her Excellency Dr. Samia Suluhu Hassan has been frontiering the maternal, newborn, and child health, and we are glad to have her as our leader in this aspect. And then I move on to Dr. Paul Chaote, who is an Assistant Director of Health at the Department of Health, Social Welfare and Nutrition Services at the President's Office. With a vast experience with the Tanzanian system, he has once worked as the medical officer in charge for the district hospital, then later he became the district medical officer, the regional medical officer. So we are glad to have him in this panel. And my question to him is, how do you ensure that implementation of mama across different regions, considering varying healthcare infrastructure and resources, how do you ensure that? Dr. Paul.
Thank you very much, moderator. Before rollout of mama, we made sure that all leaders at all levels, region and the council, are oriented on the system. And this also was initiated by official launch of the system in every region. So this made sure that every leader in a region or a council are well oriented on the system. Secondly, we made sure that we orient all of the care workers at the level of the regional hospital, as well as all facilities. And at the level of the local government authority, we instructed every facility to make sure that they have budgeted for emergency transport system so that we sustain this program. And this was done by allocating budget from various sources, including facility-owned sources and the other development partners like World Bank. So these have been very instrumental to make sure that the system is sustainable. Thirdly, we made sure that all responsible experts at the level of the region are trained, and this included the region and the council, emergency management and transport system focal person, whom were selected at the level of the region and at the level of the council, but also the regional ICTO officers, transport officers, accountants, and the assistant regional secretary responsible for monitoring. So similarly, the finance and management officers were also oriented so that they supervise clearly payment systems and they monitor every council on how they expend the finances regarding emergency transport system. So these were the crucial steps that we undertook before launch of the transport system, but also we are continuing monitoring on how the system is being operated. Thank you.
Thank you very much. Maybe you can also touch a little bit on the issue of sustainability. How do we ensure that the M-Mama, being one of the referral solutions, can be sustained?
So following development of the system, we had made sure that the every facility budget for emergency transport system, and we have designed, we have customized a system which operates to monitor the referrals, but also payment mechanism in such a way that every facility is responsible for initiating a payment and approving the payment, but at the level of the council, they approve the payment, and these payments are made electronically to the drivers through the payment module of the emergency transport system. And in this, we have collaborated well with the Ministry of Finance and the e-government, so that the system was built within the infrastructures of the government. And this have been clearly supervised by also the Ministry of Telecommunication.
Thank you very much, Dr. Paul Chaote. Now I move on to Dr. Salim Salim, who is the Director of Preventive Services, Minister of Health Zanzibar. He has vast experience at the regional and at the global level. He's a PhD holder of public health and majored into health system. And for him, I have one question. That is, Zanzibar has been exemplary in terms of implementation of M-Mama system. What is the secret behind?
Thank you very much, Dr. Ntuli. Honestly, Zanzibar contextually is fragmented with 54 islands, and we have approximately 12 islands which are habitable. Unguja and Pemba are just the major one. So our challenge was really how can we able to reach out the unreachable. But these people are actually require all those services of health, including such one of referral. After being launched this around December 2022, we went aggressively first to set up a system to allow us to make sure whoever is enrolled is unable to use that system, so that when we call them, we can able to track them where they're going. But most importantly, we send them a temporary dispatch center to enroll that, but having understanding the gap of ambulances. At the time when we trying to implement the innovation, Zanzibar has only got 26 ambulances that are registered and Ministry of Health. So we know for sure there was a gap, and that's why we have a lot of cases for women attending into local birth attendants, which cascade the evidence of how we lose women and children, because when the complication arise, then there is no way we can able to save such a situation. So we implement approximately 162 vehicles from a Mama innovation. And now we have seen the drastically increasing of facility delivery, but also we have seen intervention of saving women and children, especially those who present with challenge in the theater, become also reduced. Furthermore, we also have approximately 16 boats ambulance, which now goes to each of these islands and able to take those patients back to the main island for intervention. So of all this intervention that we've done, it has not been possible without setting up a system that has enabled us to able to oversee the whole innovation, which has been supported by Vodacom, right? So each and every one of these drivers has a mobile phone that is catered to us, and we can able to see where they are. And now we can act, when we dispatch it, we can literally see where he's going to the point of pickup. And through this innovation now, we have seen how we're curbing the curve of home delivery, yeah, to a huge percentage. But most importantly, those that we identify in an island, especially those islands with a few hundred people that hasn't got health facility, can now be actually been recognized by our community health worker, which can be linked to the health system, and now we can teaser them and monitor them to see how they progress in their pregnancy pathway. By the time they're approaching that time, the boat will be more or less on standby to able to go and pick them up whenever they need it. So we have seen serious changes since we have adopted this innovation. But furthermore, the government seeing the importance of this. We have to make sure that these people who provide the service are paid, and they are paid on time. Especially on they have the same system. Whenever they pick up, we can able to track them. When they did the mileage, we can able to pay per mileage. So seeing that, we have spent approximately just under 20 million from December 2022 to now as a wage bill towards this driver, and the government has put in for commitment approximately 50 million to allow this to go uninterrupted.
Thank you very much, my twin brother. Maybe can you also elaborate more, maybe what's an influence of the political economy in the implementation of the Mama?
Yeah, I think Mama Samia intention is really to improve maternal health indicator. This is a litmus paper in any health system. And if we fail our way to save women and children, we have definitely failed our nation. And there are so many social determinants of health across this. There are women who are encouraged to use the facility, but the facility is too far. And those who are unreachable, right, required to be unreached. So after her proposal, our President of Zanzibar, Dr. Hussein, has fully adopted that innovation and made sure that we spearheading, as Minister of Health, we spearheading the innovation and implement. And through this, that's why we managed to able to set up a dispatch center, but also we have a call center that allow, if a woman calls us, we can receive and then we can dispatch either a car or a boat that will be ready to go. And the most important part of it is to see the government has really contributed hugely just to ensure that those who render the service are being paid uninterrupted. When you pay them, they really show up and they tend to deliver most effective service that we could ask.
Thank you very much indeed. Now I move on to DODOMA Duncan, and she's a Mama country director for Tanzania. She has a vast experience working at the district, regional, and at the national level. And my question to you, DODOMA, Mama has proven to be successful PPPP. What is your take on that?
Okay, thanks, moderator. So, as we can clearly see, really, Mama is a great example of public-private partnership. And the secret behind it, actually, the first secret is, starting with an end in mind, where we had to sit with the government officials from the beginning, from, like the thinking through the system, how the system is going to work. I remember in 2022, when Her Excellency directed that Mama should go across the country within a year, we had to go back and sit on the table and start discussing on how best to go with this. So the finance that we had as partners was not enough to go across the country. So we had to rediscuss with the government and to see how are we going to co-fund the program. And for sure now the program is fully funded. The running of the program is fully funded by the government, and the partners, we supported the setup of the system. And another big secret also is, even within the government itself, it did not bring only one ministry. Rather, there are 5 different ministries that are working to ensure M-Mama is working. One of it is Ministry of Health, which is the sector ministry, PROG as implementers, and PROG finance team, which is really working on the budgeting and the financing, and then Ministry of Finance, because now, as it was clearly said by Dr. Chaote, the payments in the mainland are paid using the electronic payment system. So in that case, Minister of Health, Minister of Finance came in and built the system. And then we have IGA, the electronic government, and we also have the representatives from the State House. So in this case, all these people having different minds from different ministries come together and really plan for the implementation was also one of the biggest success. And the other one is also the full ownership of ICT. As we remember, before, when it was a project previously, the system was hosted at Amazon Web Services, but when Her Excellency directed issues of data security, that's when the system was like fully owned by the government. Actually, it was just the knowledge transfer, and they started building the system from the beginning within the local, the local environment. So those are the secrets behind the success of
Thank you. As maybe my follow-up question, how did you deal with the issue of trust? Because oftentimes what we have seen, whenever there is a PPP arrangement, then the issue of trust becomes one of the huge challenges. How M-Mama had to navigate through the trust issue?
I think the main issue is working closely together, starting from the designing of the system itself. So it's like putting all the minds from the private sector and the government sector, sitting in the same room, thinking together and, bringing in solutions together. And when we face challenge, in any challenge that we face, we come back again and sit together and think through the solutions. I think that is the major thing that really brought the trust among us as the team.
Thank you very much, Dolorosa. Now I move on to Daniel Sarungi, who is a system developer and analyst who works at the Electronic Government Authority, or eGov. And my question to him is, how has e-government technology been leveraged to enhance maternal and newborn emergency transport system? And what challenges has raised in ensuring that data security and interoperability? So these are the two questions at the same time. Please go ahead.
Thank you so much. First of all, we understand that currently Tanzania is going through major digital transformation. And the good thing is Her Excellency, Madam President Samia Suluhu Hassan, she is the frontier of these changes through the e-government authority and the ministry responsible for ICT matters. Now, talking on the interoperability, in order for a system to be interoperable, there are some few hints that needs to be observed. Among of them include the data standards, the security standards, technology standards, documentation, and other related aspects that need to be considered for one system to communicate with another system. So coming to the M-Mama system, as our previous colleagues explained, it was hosted at the AWS in Amazon. So we had to migrate the system to our local context. We had to assess the technology that we are using in building that system, and we replaced some of the technologies. We replaced some of the license-based services that we are required to have a very sustainable system, which with our expertise that they can be easy for maintenance as well. But for the security issues is among of the interoperability checklist, security standards are among of them, and that includes how data is stored, how data is transferred, how the system is communicating to another system. And there are some very, very many aspects here, as long as it is a health-related system. So there are the health information system guidelines and standards that also need to be observed while constructing the system. Thank you so much.
Thank you very much, Daniel Sarung. So now we move on to watching a short documentary film, which is 8 minutes, and from there then we shall resume with Q&A. Can you play that?
Katika limbuko la upana wa ardhi ya Tanzania lenye jumla ya kilomita za mraba zipatazo 945,087 zikijumuisha eneo la bahari mwanana. Kabla ya kushusha unyayo wako kwenye ardhi iliyosheheni historia zenye mvuto wa kipekee almaarufu kama Zanzibar, ni mandhari nadhifu inaosanifu uzuri wa paa la Afrika. inayokaliwa na wakazi takriban milioni 66.4. Miundombinu ya barabara ni usafiri wa kutegemewa, umbali bila kujali njia zenye vumbi, barabara zenye foleni kwenye mitaa yenye shughuli nyingi katikati ya miji mikubwa. Safari ya usafirishaji wa dharura imekuwa ni uthibitisho wa ubunifu, uimara na mapinduzi yanayobadilisha maisha. Kutoka zama za mwanzo mnyenyekevu ambapo machela, baiskeli, hata punda wakitumika kama safina yenye kuokoa uhai kwenye jamii, hadi kufikia zama mpya iliyotangazwa kwa uzinduzi wa kihistoria wa mpango wa mama. Mabadiliko katika usafiri wa dharura yamekuwa ni hadithi ya azimio adhimu na maendeleo ya nchi yetu. Ilikuwa ni asubuhi ya mwezi Aprili mwaka 2022 wakati Rais wa Jamhuri ya Muungano wa Tanzania Dr. Samia Suluhu Hassan alipochukua hatua ya kishujaa kuzindua rasmi mama na kuanzisha safari ya mageuzi kuelekea huduma za afya zinazopatikana kwa urahisi wakati wowote na popote.
Mheshimiwa Rais, Wizara ya Afya tulijiridhisha na kuona kuwa mfumo huu wa mama unafaa kuwekwa katika mipango mizima ya Wizara ya Afya kwa kushirikiana na Ofisi ya Rais TAMISEMI.
Mama ni suluhisho kwa kina mama wajawazito. Niseme sasa kwamba nina furaha kuzindua mfumo huu wa mama.
Kwa azimio lisiloyumbishwa na maono dhahiri ya Mheshimiwa Rais Mama Samia Suluhu Hassan, kumeongeza wigo wa njia za kutolewa kwa huduma za mama nchi nzima kwa lengo la kuhakikisha kwamba hakuna mama au mtoto mchanga atakayeachwa nyuma wakati wa dharura, inayobaini hatima ya uzazi salama na maendeleo ya nchi kiujumla. Hatua za haraka mbele hadi Septemba 22, 2023, ndoto ikageuka ukweli. Wakati kila kijiji kutoka bara lenye shughuli nyingi hadi pwani ya amani hapa Zanzibar zilipata huduma ya usafirishaji wa dharura.
Dira na maono yetu ni kuwa mama ipatikane kwa kila mama mjamzito katika mikoa yote ya Jamhuri ya Muungano wa Tanzania kabla ya mwezi Oktoba mwaka huu wa 2023. Inatia kuona kwa utekelezaji huo unaendelea vizuri.
Mama imefanyika mwanga wa matumaini na kiungo muhimu na taifa. Je, Watanzania na wadau wanasemaje?
Chungu linianzia nipo nyumbani, damu ikawa inatoka, damu ikawa damu. Nilikuwa na mama mkwe jirani, wakampigia simu driver, akafika, akanibeba hospitali. Yaani sasa mwendo ulikuwa ni mwendo ile walikuwa wananiwahisha sababu nilikuwa na hali mbaya sana. Yaani najua hata kama nusu saa tu tukafika Runguya. Kuja kupimwa nikaambiwa damu imezidi. Hapo na mtoto ni mkubwa. Nikahudumiwa vizuri tu na sasa nipo hapa duniani. Naishukuru hii huduma ya mama imenisaidia. Nikapata huyu mtoto Revocatus Kamuri. Kama isingekuwa huduma hiyo, labda ningepoteza maisha au mtoto.
Na nilishangaa sana kwa huduma walizokuwa wananipa, nikifikiria kwamba nitapata wapi kukizi hivi vitu vyote wanavyonihudumia. Namshukuru sana Mama Samia kwa kuanzisha huu mpango wa mama, umenisaidia sana. Na apate maono zaidi na huduma hii iendelee kuwafikia wamama wengine.
Katika safari hii ya mabadiliko kupitia mama na 115, usafiri wa dharura kwa mama mjamzito aliyejifungua na mtoto mchanga, wanawake wajawazito wenye dalili za hatari na watoto wachanga sasa watapata fursa ya kupata usafiri na huduma za dharura kwa haraka na ufanisi zaidi, wakitokea kwenye jamii zao moja kwa moja mpaka kituo stahiki cha kutolea huduma za afya.
Na mtoto mchanga.
Wakati ambapo madereva binafsi wanapata fursa ya kushiriki utoaji wa huduma za usafiri wa dharura moja kwa moja kutokea kwenye jamii, ushiriki wa wanaume katika kuboresha huduma za dharura ni muhimu sana. Kwa kushirikiana na jamii nzima, wanaume wanaweza kusaidia kubadilisha dhana potofu kuhusu afya ya uzazi na kuhakikisha kuwa wanawake wanapata msaada unaohitajika kwa wakati kipindi cha ujauzito na kujifungua. Kupitia jitihada hizi za ubunifu wa mpango wa mama, Tanzania inaingia katika enzi mpya ya afya na ufanisi, ikionyesha uwezo wake wa kusonga mbele na kufikia malengo ya maendeleo endelevu. Hata sasa ubunifu huu wa Kitanzania umevutia mataifa mengine kadhaa barani Afrika ambayo yako kwenye hatua mbalimbali za utekelezaji wake, ikiwemo Lesotho, Kenya, Malawi na hivi punde wataalamu kutoka Nigeria wakifunga safari kuja kujifunza ili kupata uzoefu hapa kwetu nchini Tanzania. Kwa ujumla, mabadiliko haya katika sekta ya afya yanachangia sana katika ukuaji wa uchumi wa nchi kwa kuimarisha afya ya jamii. Wanawake wenye afya na watoto wachanga wenye afya wanaweza kushiriki kikamilifu katika shughuli za kiuchumi na hivyo kuchochea maendeleo ya kitaifa na ustawi wa kila mmoja. Huu ni uthibitisho wa nguvu ya ubunifu, ushirikiano na azimio lisiloyumbishwa. Jambo moja limebaki wazi: safari ya kuelekea Tanzania yenye afya na furaha ndio kwanza imeanza. Kwa miundombinu imara kama msingi, jukwaa la mama limeandaliwa kwa hatua inayofuata ya safari. Safari iliyojaa si maili za umbali utakaosafiriwa, bali maisha yaliyoguswa na kuokolewa kwa watu walio kando ya njia. Huku rais akijiandaa kuzindua rasmi 115, mapigo ya moyo wa Tanzania yanazidi kasi kwa matarajio, kwani inatangaza mustakabali ambapo hakuna mama wala mtoto atakayewahi kuwa peke yake wakati wa dharura.
Namba 115 wakati wa dharura.
So I think, Dr. Makwani, you watched this documentary, and now what can you say about the insights and the long-term strategies as far as the Ministry of Health is concerned, relating to what you have just watched to what is happening at the Ministry of Health, especially at your department?
To be sincere, first of all, it is very encouraging to see these changes are happening, whereby we started at a point we are not sure how to communicate, how to reach a woman in need, how to reach a newborn in need, how to reach a child in need of services of transport to save life. Now, at least, we have managed to achieve that goal. Currently, our healthcare system has changed. As my colleague was saying, maternal, newborn, and child death is like a litmus. We've come from stages where we did not have services. The coverage was very weak or very small. But currently, we have a huge coverage of health facilities in Tanzania. And when you go to those facilities, yes, we do have inadequacy of human resource, but there are at least somebody who can provide these services in those areas. And possibly this gives us a huge gain we have seen, whereby we have managed to reduce maternal mortality in a very short time, from 2016 to 2022 by almost 80%, from 556 maternal deaths per 100,000 live births, and currently it stands at around 104 per 100,000 live births. That is a huge gain. We have reduced again child death by almost 35%. That is from 67 to around 43 deaths per 1,000 live births in the same period. That is another huge gain, huge gain. But we do have some issues unfinished agenda, the biggest agenda. First of all, we have not attained the same gains in newborn care. From 2010 to 2022, we have seen there is no statistical significant change in terms of reduction of newborn mortality. You understand the numbers read from 26, 25, until recently it is 24 per 100,000 live births. So there is no statistical significant change in that area. This is an area of investment for us. Fortunately, we know why. Because somehow, in terms of coverage of neonatal care services in Tanzania, there was a huge marginalization. And that's why we are trying now to accelerate towards having many facilities so that the coverage of these services becomes somehow the same all over the regions up to the district levels. And we hope by 2025 we'll have that much coverage, and from 2025 reaching to 2030, we are likely to accelerate in terms of reducing mortality for the newborn. When it comes to maternal death, the approach is different. We have huge coverage of services in the country, but the major challenge in that area is issues of quality. I would say most of the maternal deaths which were caused by issues of coverage of health services, issues of availability of human resources, those maternal deaths have been taken care of. But the issue of quality, now it is an issue which is giving us problem. Our reviews show that 85% of the deaths are caused by issues of skills, related to skills. Around 78% of deaths, the cause is around issues of practice and attitude. And here, practice and attitude, I would just put it in a simple language. Practice, I've been doing this all years. Every day, what are you telling me? That needs to change. When we say issues of attitude, someone you are called in an emergency, you don't turn up in time. These are the issues which we are dealing now. But to manage them, you need to have a very strong leadership and accountability. So those are the three areas that we need to deal at this stage. We need to invest more on issues of skill. We need to invest, number two, issues of practice and attitude. We need to invest heavily on issues of leadership, which is cross-cutting. Yeah. So that is a way forward. But where M-Mama has taken us a way forward, saying that now we can breathe on issues of transport. But you have seen the recent rainfalls, what is done. Liwale was cut off from within, was cut off from the rest of the nearby districts. And when they needed referral, they were unable to use vehicles. They were unable to benefit from the usual M-Mama we are using. We need to think differently.
Thank you very much, Dr.
A district like Mafia, the same. We need to think differently. And this is an area whereby we are saying, now our idea, we need to advocate to add another piece, air ambulance, to some of the places. I submit.
Thank you very much. Indeed, we need to have strategic and selected investment for us to be able to bend that curve. Now I'll move on to Dr. Paul Chaote. I think you also watched the documentary. My question is, one of the major transformations in M-Mama is the use of community taxi drivers in the absence of ambulances. In what ways are the community drivers actively involved in the maternal and newborn emergency transport system? And how do we ensure that their continued commitment and support prevails? And then the next question to Chaote is, what are the plans to ensure that the community is aware, engaged, and also support the system?
Thank you very much. I will start with the awareness of the community in support of the emergency transport system. So before starting this implementation, we made sure that the local community is well oriented. In this case, the village executive officers, village chairman, and ward executive officers were oriented on the system. And these are the people who were actively involved in the selection of the drivers in collaboration with the other local leaders. So this made sure that we identify a committed and a responsible driver who will help in referrals from the level of the one facility to another. So after the drivers were selected, we collaborated well with the police force to make sure that they are trained and their cars are inspected so that they are roadworthy. Subsequently, they were entered into the contract with the respective local government authority. And in this case, the legal officers were effectively involved. So we have a contractual agreement with them, and to fulfill them with the payment modality, we discuss on how much they will be paid according to the mileage, according to the local context. So they were agreed on the payment modality, and the challenge came is, as we know how the government usually works with the payment systems, so that's where we designed a payment mechanism so that after a driver have completed his or her route, will be paid promptly. Initially we had challenges, but then as we went on, we designed a e-payment system in which we opened an account at the central level, the Bank of Tanzania, and it were linked with a government payment system through GPG, so that in collaboration with the other banks, we made sure that a driver is paid directly to his phone through MNOs. So this is the system which is helping us so that after just the driver have completed his route or her route, is promptly paid through the central payment system. So in this case, the facilities are both involved to make sure that they contribute to this central account. And also, if there are other partners who are willing to support the system, they usually contribute to this central account, in which case the every council has it. The current system now is we have ambulances. So the ambulance operates where they are available. So in case they are not available, that's where we engage the community drivers. And in this also we are looking forward to make sure that we monitor closely the ambulances, but also the drivers are going to be monitored through the app that is under development, in which case the driver will be monitored in real time using the technology, but also the ambulances will be tracked and monitored in real time, and not depending on calling them through their phones. So the geographical location of the ambulance or a driver will be correctly located, and the close ambulance in real time, or a driver who is close to the facility. So this will help to minimize the delays which might happen in case we need a driver or we need an ambulance. Thank you
very much, Dr. Paul. Now we move on to Zanzibar. And how do you ensure the sustainability and scalability of the M-Mama to the communities in Zanzibar?
Yeah, thank you, Dr. Ntuli. Honestly, this innovation has greatly proven to save life. Currently, as we speak in Zanzibar, we have picked approximately 3,000 patients that were needed to be picked by this service. In the absence of this vehicle, these are the people that we could have missed. obviously they did attend, but most importantly, we know for sure that one of the driver where we lose women and children, a free delay model, right? Is either delay deciding seeking care. On that approach, we have used our community health worker to really try to emphasize the woman to seek care. When that decision is made, now is going to be delay to receive care, right? And then that's where the mama taxi comes in, right? But then when they get to the theater, Dr. Makwani has explained on the importance of our HR to behave well and to be capacitated to do that, because we really have to go to the root cause of the problem if we really need to improve situation. But in Zanzibar, like I say, we have captured 3,000 individuals who needed this service, and some of which are on those really hard to reach islands. They have been shipped by the boats which are there, and it's so important that that innovation do works. Yeah, we have, like I say, almost 12 islands out of 54 which are habitable, and some of these islands does not have health facility. So the government have seen the priority of this. That's why we managed to make sure we have some serious budget pending aside to sustain this modal innovation, but also we have innovate our universal health insurance, and part of the resources are going to support a mama. We also have been supported by World Bank and other partners who have really come to hands to support our innovation. But most importantly, as we have seen that this innovation do save life, we do believe there is a need to have more investment into it, because from 22 ambulance to 233 ambulance, that number speaks the volume on how many people could have been left unattended.
Having a strategy for domestic financing is key for sustainability. Now I'll move on to Dolorosa. We have seen people coming, flooding in from different parts of the continent and also at a global level. So what could be the reason why people are coming to actually learn about mama?
Okay, thanks, moderator. So, as we have clearly said, it's true that actually mama has started in other countries. Lesotho is now across the country. This is the second year for them, and Kenya itself. And let me just quote Samantha Power, who is the administrator of USAID. When she came to Tanzania last year in June, she said these words, like, actually, the results speak by themselves. So in that case, really the major reason why it's attracting global attention, the first one is because of the impact or the results it has. The second one is also affordability. It's really affordable, as it was clearly said. You know, it's within government capacity to really ensure the emergency transportation is available for mothers and babies, and this is across sub-Saharan Africa, because even in other countries also, the government really takes over. And the other thing is also the power of public-private partnership. As we have seen in Tanzania, yes, we have private partners like Vodafone Foundation, Vodacom Tanzania. We have USAID, which is also public partner, and we have the government itself. So, you know, like bringing different partners into this from public and private has really been a great secret behind the success of this. And the other thing is also its technology itself is simple and scalable. Like it can be adapted by any other country and, you know, work well in any environment. So all other countries that have, you know, learned from Tanzania, they have adapted and contextualized it in their own environment. Thank you.
Thank you very much. I'll come back to you because I wanted at least to give us a snapshot with the current data, what is happening as of today, as far as the mama system is concerned. Okay, so Dolorosa, can you?
Okay, as we can see, I hope everyone sees the screens. So since the start of mama, we can see over 71,000 mothers and babies have been transported. Among them, over 58,000 are mothers, and over 12,000 are babies under 28 days. And those ones, 128, those are both mothers and babies. Like, you know, you find a situation when a mama and a baby at the same time have an emergency. So in general, if a mama was not there, like, we could have lost those lives. That is the estimated number of lives saved, almost 3,000 mothers. So as you can see, we are across the country now, and I'm not so sure if you can go back and just, we can see the Africa map on the countries. Sorry.
Okay.
Yeah. So this, okay, you can see now, this is Tanzania, and down there it's Lesotho. As we said, Lesotho is also live now. And within, like, from July this year, Kenya will also be seen in this. This is a multi-country dashboard. Of course, we have different types of dashboard. This one is multi-country, but I'm sure Daniel is going to speak about the M&D dashboard. So in general, we are having a real-time data, and this really supports, you know, it really helps leaders at different level to be able to see what is going on and also use those data to make better decisions in the improvement of quality of service in different areas. If now there's no live emergency, as you can see, but if the live emergency was there, we were going to see the details. Sometimes you can see like 20 live emergencies within that hour. And for now, with the data that we have, in every month, we have around 5,500 mothers who are transported across the country, which is like equals to around 200 within 24 hours and around 80 emergencies within 1 hour. Yeah.
Thank you very much, Dorosa. I really appreciate for that. Now I'll move on to Daniel Sarungi from Tanzanian experience. That we have had so many great systems which were established and then later died off. So how do you ensure that the Mama system will be sustainable?
Yeah, thank you so much. First of all, I would like to add on that the M-Mama is one of the very first digital solutions that we have exported out of Tanzania. I just want that to be clear to all of us here, because we should be very, very proud of that. Coming to the question, the first thing on the sustainability of the system, the one of the many very strong reason becomes the business process owners. If the business process owners have buy-in and they are willing and ready to use the system, they enjoy the system, the need for that system will always raise. And if the system is not available, there are some concerns that may start to raise because it has got the interests of people. But when it comes to the technology side of view, one of it is always the availability of the system and accessibility. So we have stored the system in the government data centers to ensure that the system is available and it is accessible at any time. But again, we rebuilt the system with our own technology so that our expertise can be ready for support when it comes to the maintenance and the sustainability issues. So we built the system with our local expertise from different ministries, that is including e-government authority, PORAG, Minister of Health, Minister of Finance, the State House, and all together we built something that is sustainable and we can provide support at any time that is needed. But again, we try to avoid, while we are doing the technology analysis review, we tried to avoid the services that require license-based services, because sometimes the system might not be sustainable due to the licenses. So we tried to replace the license-based system services with the open source solutions that are easily to be conducted under the government supervision. But another two things, the vendor lock solution, some of the solutions are not, you cannot do anything in the system, or without a certain technology, it cannot be interoperable with other systems that is existing in the government. So during the integration with NEPA, with the MUSE, GPG, and other systems, it was become easier because it's our own expertise that we have put in place.
Daniel,
Thank
who
you so
developed
much.
this system? Who developed this system?
The system was developed by the government experts, the local. experts, and we are very proud of that. And now we are exporting the system to other countries. Thank you so much.
So this is a homegrown system, so we are very proud of our colleagues from eGov and other ministers of health, PRAJ, having contributed into the development of this system. Ladies and gentlemen, now the floor is open for Q&As. Can I see the hands up? We start with Dr. Mtei, then we move on to Dr. Ambrose. Yes.
Thank you very much for the very nice presentation and the very nice innovation. Just excellent. I have 3 questions. 1, how are we ensuring security from fake calls? Security of drivers and the vehicles. 2, how are we advising mothers not to wait until they use the system, but to report early at facilities, especially those who have risk factors already identified? 3, what is the policy on maternity waiting homes, the Chigonelas in Dodoma and the Chikandas postnatal waiting homes? Thank you very much.
Thank you very much. And you remind me, you being one of the champions as far as the establishment of Chigonela as a maternity waiting home here in Dodoma. Asante sana. So now we move on to Dr. Ambrose. Ambrose?
Thank you very much, and for the very good innovation. I have listened to this presentation before, and I ask myself, at what stage did the experts sit down to find the solution? Because it's one thing knowing there's a problem, but then being able to know who other stakeholders can come in to collaborate and design together. And also looking at the results as of today, how many transfers and emergencies, could we also categorize further to look at how many C-sections were done of the mothers referred, how many resuscitations were done, how many bad outcomes were registered? So somebody can be able to see the actual outcomes rather than focusing on the outputs. I know that data might be there, but then for the benefit of people appreciating more of the bigger picture, that would be very critical. And then my other question is around the policy dynamics. There are many countries interested in adopting this innovation. Their biggest challenge will be around what policies need to be revised, agreed upon at country level to ensure that you can be able to make an improvement of a financial transaction on your phone, on your computer. The biggest challenge, I come from Uganda, and the challenges we face is around interministerial, inter-policy, interoperability, where to get a letter, one letter approved by 2 ministries, what about a financial transaction being approved by 2 different sectors of government? So as a country here, what kind of policies did you have to first review before you could go into that kind of implementation? Thank you very much.
Thank you very much. So I will throw one question to one person in the audience, that is Professor Bruno, and I would love him to respond. That is the role of research in the implementation of M-Mama system in the country. Can I see other hands? Yes.
Yes, thank you, Chairman. My name is Dr. Saidi Kilindimo from Muhimbili University of Health and Allied Science. I'm an emergency physician. My question a bit of transport, be it obstetrics emergency or life-threatening emergency which could occur. What are the strategies in place to mitigate the bad outcome could follow after the involvement of experts like emergency physician on planning of en route transport of these emergency patients during and within this project? Thank you.
We shall go into the next round of Q&As. So we start with Dr. Makwani. Any response? Then we will skip to Dr. Slim.
I think, first of all, I wish to answer this issue of maternity waiting home. I think that is a very policy question. First of all, we still embrace, despite of positive data to support its reliability, but we still embrace it, especially to those hard-to-reach areas. You know, there are places whereby the ambulance goes and then it stops somewhere, and then someone has to transport a patient from the mountain there down to the hill so that that patient can go to nearby facility. In such environment, we embrace issues of maternity waiting homes. We have not thrown away your idea. We still keep it, and it is still viable. But again, it is an area which is lacking data to support it. The other area on transport of files from one office to another office, and you get problems, I would answer in this way. First of all, our colleague from the EAGER team gave an insight previously, and possibly is going to speak more about it. In Tanzania, currently, the government is working hard to go to paperless. And currently, I'm acting in one of the big offices. I see more files in electronics. I have a permission as well. But usually, we want to work while we are in office. So at least we have moved that area whereby we can push files using electronic system. That is within the same office, but sometimes it goes outside the office. The file goes there. So the system which is being used for the payment, it is a government system which has been ratified whereby you can pay. And actually it controls unnecessary frauds. And it is working very well in our country. And I don't know how many regions have graduated currently for the system. 4 regions, All regions have graduated to use the system. So for us, we embrace the use of e-government approaches, and maybe my colleague will add more on this area.
Thank you. So digitizing and digitalizing the healthcare system is quite very important so that to navigate through the bureaucracies. But the other thing maybe to add, I think the research appetite for maternity waiting is quite very low. Maybe we should call upon now researchers and academias to venture into that. It's quite very important. The body of evidence is quite scarce, and we need more evidence around that area. So now we go to Dr. Slim.
Yeah, I just want to add up from where Dr. Makwani has left, emphasizing the question or opinion of our senior. We have got this inventory now underway, but we need to really give the community the ownership to really embrace this, because I believe in Tanzania there are yet people who are aware of this, and by using our community health worker to really, and our health promotion unit to really go and making sure that people take the ownership of this innovation, so that we don't attain to the mom when there is actually a critical, when those early signs are there, so that women, they need to be identified so that we can able to intervene at the earliest to try to avoid consequences that could probably compromise the life of a woman and children. That's all I'm emphasizing. So the community need to own this, So in that way, we weren't able to receive a fake call, right? Because we will be able to see whoever really seek care. Most of them will already be identified that they are in the potential of seeking such service. So if we operate that way, there will be a synergy between the recipient of the service and the one that provides the service. Thank you.
Thank you very much, Dr. Slim. Now I move on to Dolorosa. Dr. Paul.
Thank you, moderator. I just want to add, start on the issue of security of the drivers. Yeah, as I said earlier, that the drivers are identified by the local leaders. That's the village or the entire responsible. So in this case, they are usually recommended by a credible person to the village authority so that they are clearly known. And these drivers will only be contacted by the dispatch center. Not everybody, not any healthcare worker will call the driver. And the numbers which are responsible, as you heard a day before yesterday, that which was officially launched, is the number which is used to call the drivers. So in this process, we make sure that no one will contact a driver who is not known to a driver. And then all drivers who are contacted, they are already have passed through a strenuous process of identifying them. So also I will touch base on the issue of policy changes before implementation so that the process of payment to the drivers is clearly implemented. In this case, we did not have to change any policy because in Tanzania we have already moved to most of the processes are already digitized, such that at the facility we have a system which monitors system with the MMAMA system which is used by the central government, that is MUSE, and this is the account that was linked to through GPG. So in this case, we did not have to change any policy because already the systems were there. It was just a matter of integrating the systems.
Thank you very much, Dr. Paul. Now we move to Dolorosa.
Thank you so much, moderator. And actually, I would like to respond to the question on the impact. And I heard Dr. Bruno is in here because he was one of the, when they did the MUHAS evaluation previously.
I've asked him a question to respond.
Okay, so but now again, recently we did baseline, midline, and now we are doing endline evaluation of it. And I would like, if you can please support to just show it. But generally, MMAMA has proved to improve the emergency transportation by 100%, as you can see in the slides. You can see, so access to emergency transportation has been over 100% by now, and it is proved to, like almost all emergencies, actually over 99.8% are going from the lower level facilities to the higher level facilities, showing that it's really, those emergencies are the ones that really need, referrals. The 0.2% is because of, the CMOC to CMOC referrals, and because of different reasons, including sometimes maybe mtu wa usingizi hayupo, so you need to really refer to another CMOC center to just ensure correct support. And all health centers be more support to the mothers who need maybe additions from MUHAS.
Thank you very much. Maybe
it was MMH way long before for reaching these milestones. But the role of research here was really taking evidence and modifying the intervention and shedding out those components that were not as effective, moving on to something that was more affordable, but also mitigating those delays that happened. So it was a collaborative, which again is a strength of any intervention that you would wish. It was community-based, starting from the community, owned by the community. And as Dr. Chaote mentioned, the communities to the facilities. They owned they will say that, we have decided to remove this part because it was not working in our area. Now, when we checked, when we discussed with the implementers, we noted a number of trainings, and each training meant to improve an area that was a challenge in a bit. Dispatchers, those people who were actually making or triaging the patients, and even the drivers. You know, these are community-based colleagues who make community. It was easier to do that. At the end, when we did the final evaluation, this intervention in Shinyanga region, this intervention saved not only lives, but also the trust of this intervention was very high in the community, because people thought it was theirs and that someone else was just supporting in a way, but they took it as their own. Another important thing was cost effectiveness, which has not to the government ambulance system that you could have as such. The last thing was that, and this was also our recommendation before even we say that it should now be scaled to all regions in the country, was that each region, each place is quite unique. The problems that you find in Shinyanga will definitely be different from here. And learning and keep learning while modifying the intervention is crucial. If you don't want to crash, you need to take all those constraints around the program and where the people are implementing it into consideration. There will be challenges, of course, in acceptance in some areas. There will be challenges in human resource. There will be challenges also of access even to this transport. So each area has its own set of problems that needs to be taken care of while we escalate or while we scale up to the nationwide. But so far, it was really an innovative, homegrown solution to address the own challenges that we have. Thank you.
Thank you very much. Bruno, apart from being a professor, is also a well-established researcher with more than 71 citations to his name. Can you applaud him, please? Now the follow-up question, Bruno, and then we move on to Daniel.
This is a problem not to so many places, but of course urban and rural combined. It's not a problem that is everywhere, but in selected areas of the country. Mapping is very important, but evaluation of what was done before and looking into challenges of where we fall, it's quite crucial. It was really useful when we evaluated it. Remember when you were in Shinyanga, when we evaluated the maternal waiting homes in Shinyanga, we found quite interesting results out and so forth and so forth and so forth. But this, if they have to be strengthened or, or maintained or uptaken, they have to be, at least sustainability will be an issue. But if these initiatives are community owned, they will force you in your office to go and operationalize them. So we really need to look into factors into where they were successful, how they saved lives, and actually own the people in the community so that they are theirs. Because as we discussed earlier in the challenges that were actually in those, so there are also all these traditional cultural beliefs that we also need to take into consideration. But if these are owned by the people, it's quite changed. The results and papers that were published through the evaluation of MMAMA, 3 of them are in the international peer-reviewed journals. They are open access, so colleagues can go and read all the findings that we had in Shinyanga and see how now we can strengthen the nationwide programs. Thank you.
Thank you very much. I must say, MMAMA is one of the initiatives that have been well documented, and we are very proud for that. Now I move on to Daniel.
Thank you so much. Adding on the policy dynamics, especially when it comes to the digital transformation and ICT-related activities. The e-government authority has set standards, policies, and guidelines that cut across all public institutions. They all follow the same standards that have been set. And has also set standards for data sharing, including the platforms for enterprise service buses that allows data to move from one institution to another institution. So that makes it easier for these different ministries to communicate, like our colleague have just said, some few systems like e-office and MUSE and GPG to communicate seamlessly. And if you refer, just the quick one, if you recur to the last GovTech maturity report from the World Bank, Tanzania was ranked the second in Africa in the best e-government services. So we believe that for the next report, we will even be the first one, the first one even more than the first one, if it's possible, due to these initiatives that are ongoing. So I really appreciate this, and I do thank you so much.
Thank you very much. So now we go into the second round of Q&As. Can I see the hands up? Yes, at the back. Can you send the mic? Yeah, that's Dr. Kin Gienze.
Thank you, moderator and the presenter. I have just one question, especially related to the research that have been conducted to this project. So I was a bit late to come to this hall. Probably some of the presentation or data or evidence have been presented. Mine is a question on the economic studies, especially on the cost effectiveness. Have we conducted any study on cost effectiveness of this intervention?
Yeah, that's a very good question. I think Bruno will have to respond that as well. Can I have, hello, move to that side? Let us be brief to the point, and because time is not our good ally.
Thank you for a very good discussion. I'm Paul Michael Andrea, the CEO for Tanzania Mentors Action, and we are doing mentoring. I just want to congratulate the programmers to decide to cross-border Tanzania, because most of the innovations have been just remain here in Tanzania. But for the first time, I'm happy to hear that we want to cross-border. Now, my question is, what is the incentive mechanism in place to motivate the private sectors so that they can fast-track the implementation of this?
Thank you. Yes, to Esther.
Supportive system which CHW may use when they encounter technical issues or technical queries while using a MAMA system. Another question is, have you also think about feedback mechanism which maybe CHW may use when they are using the MAMA system, which can be able to report back to maybe coordinator or someone who can support them and get maybe, so as to have sustainable or effective system. Thank you.
Thank you very much. So I now move on to Professor Bruno for response. One minute, please.
Yeah, thank you. I'll use half of that. One of the things that we looked into when we evaluated was cost effectiveness. And in the 6 councils that this was piloted in Shinyanga, a total of 900 and I think it was 980 referrals were completed, majority of them, of course, being through a MAMA. The cost, $70 vis-a-vis $472 for the government-owned referral systems. I mean, the emergency system, which are the normal ambulances that we have. The completeness will be the same, but the cost of running, completing to the government system. So if you compare the two, it was very easy to do that.
Yeah,
Thank you.
It's quite very cost effective. And also, we are working with UNICEF to come up with an investment case to know for every single dollar invested in MMAMA, what is the return on investment. And we believe that could be one of the economic studies that will help us inform our policies in the country. Now I'll quickly move to Sarungi to respond some of the questions and also to give us the take-home messages. 1 minute.
Thank you so much, moderator. For the question that have been asked, most relate to the user departments, and I'm very sure that they will take care of. For the M-Mama, it has the proper scenarios that might lead the feedback to ensure that the case has been delivered and from the start and up to the end of the case is well documented and can be used for the analysis of data later. But for the programming and the technology in general, I do think that we thank you so much, and we thank Her Excellency, Madam President, for ensuring the digital transformation is moving forward in our country.
Thank you very much, Daniel. Dorosa, 1 minute.
In addition to that, regarding the feedback, also we've partnered with Mama na Mwana UNICEF, where they really help us, to ensure that they evaluate the quality of the transport that mothers got. So in general, my last message will be, guys, PPP, let's embrace private-public partnership because it really works and it can bear great fruits. Thanks.
Thank you. Slim, 1 minute.
Yeah, thank you, Dr. Ntuli. Obviously, we've seen evidence here which explain the reality that how this innovation has been impactful to the people of Tanzania. And obviously, the commitment of both President Her Excellency Dr. Samia Suluhu and the President Mwinyi in Zanzibar has shown that how much country need to cascade this. It's probably most important that our partner need to get on board to support this innovation, especially it gear up to target most important health indicator in our country. Thank you.
Thank you very much, Dr. Slim. Chaote, 1 minute.
Thank you. Thank you very much, moderator. I would like to respond on the issue of CHW. That first, the CHWs are the first responders for the case of community to facility referrals. So this will be very instrumental in making sure that we actually serve a required mother and not just anybody who can go to the facility by themselves. So this is very important. And currently we are customizing the unified community system, which will be used by CHW. And this system currently is already linked with the centralized GoToMIS, as you heard yesterday, for those who attended the session, but also will be linked by a MAMA system, so that we'll be able to track the referrals from the community and the community health care workers. The information will be accessible to a MAMA and to the central data warehouse in DHIS2. And I would like to conclude by saying that M-Mama is one of the systems which exemplifies how the government can be clearly coordinated to make sure that the initiatives within the government is well coordinated and effectively implemented. Thank you.
Thank you very much, Dr. Paul. And now, Makwan, 1 minute.
Thank you very much. I would say this is an area where we have done very well in terms of advocating to the change. And for me, the message is very clear. If you want to have a reliable, sustainable change, advocate for policymakers to take a message for whoever wants to take a MAM. I submit.
Thank you very much. Disease, medical conditions start from the communities and they end in the communities. Let us embrace PPP. Let us embrace technology. And let us make sure that the CHW are at the center of any intervention. Thank you very much for your attention. And so we have been given another 10 minutes, so I'm very happy for that. After lunch, we will have to reconvene here. So for now, we have 10 minutes more. And I saw Saidi. Maybe we start with Saidi.
And I was asking about, on the good number we have, we embrace that. But my question was on the other side of the good number, the incidence of emergency during transport, being this, if it happened during transport. And my second question in this project, what was the involvement, the role of involvement of experts like?
To that, but I can see something in Eric's face. He must be having something to say. Can you, Eric, you must have something to say with regard to a mama. And then Dr. Anna Nswila will be next. Eric, please.
Sorry, I came in very late, so I really don't have a specific question. Just so let's take this as the number one, but now we are waiting for 2, 3, 4, and 5, where we convince the leadership to take up PPPs as a core avenue to progress. Thank you.
Asante sana. Dr. Anna, we want to hear your voice.
Okay, good morning. La kwangu ni kwamba, as Dr. Maskwani said, anything approach political will na commitment, the country will move. But again, take into account kuwa political ikipotea hiyo, what will be our, tunatakiwa tuwe na strategy za nyingine namna if this changes like an organism may change njia, lazima tujue tunatakiwa kufanya nini in the health sector. La tatu, PPP kama ilivyo mama cannot succeed alone. Inahitaji to work with the other partners ambao also are part and parcel of the PPP. I know there are so many interventions which has been done before a mama, but also they are dealing with the maternal. Nafikiri kuna project nyingine wanafanya faster, kuna fast track projects na nini. So we need to consolidate all those other which has been done. Yani kuna nyingine ambazo zimefanyika, tunatakiwa zote tukusanye tuweze kuzifanya kwa pamoja ili tuweze kudocument the main thing katika hilo kufanya. Thank you very much for this.
Asante. Now I move mic to Honorable Rashid Saif. Pale.
Thank you. I don't know what should I say. The system is marvelous. It's really a great and a huge transformation that has supported Tanzania to make a change in one of the key barriers to address maternal mortality, to address the reproductive health overall. And we are proud of that. What we need to do is to see what next after what we have already changed. We have now addressed the component of transportation, the areas at which a pregnant mother, a newborn in need will be at the facility as early as the time, and we need to address now what is going to be done at the facility and to improve the quality of the services that will be rendered at the facility once the mother has arrived on time. Thank you.
Thank you. So, kuna legend mmoja alikuwa bado, Dr. Mtei, malizia afu tunakuja pocha wote. Hao ni ma legends.
Thank you very much. Actually, I still commend the innovation and the approach. And we need now to center on the services at the center, at the facility level. It is very important. And when we are doing a cost-effective analysis, we should not only think about money. We need also to cost-effectively cost lives saved. Thank you very much.
Thank you very much, Dr. Paul, for the questions which were asked by Said. Wakati huo DJ tuandalie wimbo ule wa mama.
Thank you, moderator. Regarding the issue of incident of emergency during transportation, so we have two scenarios depending on the condition of the client. If it is the facility to facility referral, then a healthcare worker would escort a client. But now, when we are now thinking of moving from the community to facility referral, this is an area which we take on as an area for further consideration. And in this case, is where we are going to see how we can effectively use the community healthcare workers to address these challenges. And regarding involvement of the emergency physician, well, we understand we have been closely working with the emergency physician from Muhimbili, and the ministry is closely contacting them and in case of advice, and I know they are quite engaged during even the setup of the general emergency transport system, in which case we have started with this Mama initiative. Thank you.
Asante sana jamani, naomba muungane nami kuwapongeza sana panelists wetu. Na sasa namkaribisha DJ kwa kuendelea, sisi tunaendelea kupiga picha hapa mbele. Asanteni sana. Wapiga picha tunaomba tupige picha na our panelists kwa kazi nzuri waliofanya.
Asante sana. Can we give them a big round of applause, and to the moderator, tunakushukuru sana. So it's lunchtime now. We shall all come back in this room. DJ? Naomba punguza sauti kidogo. I've found some keys. If someone has misplaced his car